Welcome to our 8 questions in 8 minutes. It's a program where we ask our speakers and experts a lot of questions that are clinically relevant and basically are challenging to our clinicians in their clinical practice. Today, we're going to focus on pediatric nutrition and a lot of these challenging questions that are going to come up with us. Today, we have with us Dr. Beth Leonberg. She is an associate professor and Director of Dietetics Education at Drexel University in Philadelphia. Welcome on board, Dr. Leonberg. We're very, very glad to have you on with us today. We're going to start with our first question. What are briefly the key nutrients and their timing for proper brain development and brain health? And are we doing a good job for avoiding ADHD and autism, for example, knowing that they are related to a lot of these key nutrients?
Yeah, so the first 1,000 days, the time from conception till the 3rd birthday are really the key time for us in terms of these nutrients and development.
Okay.
And the nutrients that we're most concerned about are the essential fatty acids and 2 really critical vitamins, minerals, or two minerals really, iodine and iron. And so it's super important that both pregnant women and their babies, either through breast milk or through infant formula, get adequate amounts of those specific nutrients in order to develop the brain and prevent any kind of neurodevelopmental deficits that could impact the child for a lifetime.
We're going to move to our second question, gut health for pediatrics. This is a very hot topic nowadays. We know it's set for life by the microbiome is set for life by the age of 3. Many of the diseases result from disruption of the microbiome early in life. What's your intake on that? And what recommendations do you have to get that right from the beginning? And any role for probiotics there?
Yeah, so we're learning more and more about this all the time. It's a really exciting area of research. And I think that it's still completely not completely understood. So there's a lot for us to learn. But the one thing that we do know is that the most significant effect on the microbiome of the infant is from breast milk. And so it's critical that we try to get babies successfully established, breastfeeding is successfully established and get babies latched on so that they're getting the benefits of breast milk as much as possible for the first year of life. That's what's establishing the beneficial microbiome. And when we put babies on infant formula, we know that it significantly alters the microbiome. And whether that alteration is the thing that is making increasing the susceptibility to epigenetics, to disease presentation, is sort of yet to be understood. But what we do know is that breastfeeding and breast milk is what establishes the healthiest microbiome. And so it's what we want to encourage every mother to do if at all possible.
Let's move to our third question. Picky eating is classified as a feeding difficulty characterized by unwillingness to eat familiar foods or try new foods, as well as strong food preference. Picky eating represents a nightmare for parents as well as for clinical dietitians. What is your take on that, and how do you see it manage it, or how do you manage it in your clinic with your patients?
Yeah, picky eating is a big challenge for everybody. But one of the things that I think is really critical in terms of managing picky eating is to help parents understand that picky eating is a normal stage of development that every child goes through.
Try to explain that.
It's something that in some children they pass through sort of picky eating relatively quickly. And others, it may persist for a long period of time. But the idea that a child wants to choose their own food, have some control over their own food choices, is normal developmentally. And it's something that we need to help parents understand. And then we need to help children to be able to make those choices in a positive sort of way that doesn't create behavioral problems. what really is the problem isn't the picky eating itself. It's the behavior that goes along with it that maybe persists because of the way that parents react or don't react to their child's pickiness.
Great. We're going to move to our fourth question. In the 2020 Global Nutrition Report, undernutrition coexisted with overweight and obesity and other diet-related non-communicable diseases. What is the framework dietitians need to develop for facing this growing trend with individual patients and using this individualized approach that you always preach about?
Yeah, it's a really interesting phenomenon that we have these two sides of the coin happening at the same time, right? That we have undernutrition and overnutrition in the same population at the same time. So the thing that makes it really exciting for dietitians is this is what we are trained to work with families on, which is to choose healthy whole foods and go for the things that that are going to nourish the child, both the undernourished child and the overnourished child, and provide the vitamins and minerals. So that means starting with breastfeeding, really emphasizing the importance of breastfeeding, emphasizing the importance of nutrition during pregnancy, but breastfeeding, the delaying the introduction of solid foods, and then when we do introduce solid foods, introducing whole foods, rather than processed foods, introducing fruits and vegetables in their natural form, introducing whole grains and meats. All of the whole foods rather than processed foods will help children to get started on a path that leads into a healthy weight and good nutritional status, as opposed to either direction, as opposed to undernutrition or overnutrition.
Let's move to our fifth question. When can we offer peanut butter to children, and what's the take with the latest guidelines from the American College of Allergy, Asthma, and Immunology? I have a small paragraph that I would love to read for you. In 2017, the National Institute of Allergy and Infectious Disease sponsored addendum guidelines for the prevention of peanut butter. They recommend the introduction of peanut butter containing foods to high-risk infants beginning at 4 to 6 months of age, and all other infants around 6 months of age, or in accordance with their family and cultural preferences. More recently, the North American and Canadian Allergy Societies issued a consensus statement, again recommending the introduction of peanut and egg to all infants starting around 6 months, but not before 4 months. The most recent European Academy of Allergy and Clinical Immunology guidance also suggested the introduction of well-cooked egg once solid food introduction commences, and suggested the peanut should be introduced as part of the complementary feeding in countries where peanut allergy is prevalent. So what's your intake on that?
Yeah. So what we have learned in recent years is that our thinking for many years about this was just completely backward, where we were educating people for the longest time to avoid these highly allergic foods, the foods that tend to have the highest incidence of allergy and that tend to produce the most strong allergic reaction, particularly peanuts. What we've now learned is that is absolutely contributing to the higher rates of peanut allergy that we're seeing, and that in fact, when we reverse it by offering these foods early on, we essentially begin the desensitization process for the child. And so early introduction in small amounts is helping the child to become desensitized and not react to those foods as they get older. The 4 to 6 month time frame corresponds to the same time frame that we recommend for introduction of complementary foods. So what we're saying is, at the time at which it's appropriate to introduce complementary foods to children, we should be including in that array of foods that are introduced these foods that are highly allergenic, so peanut and egg, which are the two that are mentioned there, because the earlier introduction of them decreases the likelihood of later food allergies.
Let's move to our sixth question. Restoring breastfeeding is a major goal for pediatricians, midwives, dietitians, and lactation advisors, and yet mothers are shying away from this practice. Can you share some strategies to follow clinically to help restore the practice with our patients?
Yeah, I think probably the best guidance comes from the World Health Organization and their 10 steps to successful breastfeeding, which really cover the whole gamut of issues that kind of get in the way of mothers breastfeeding. Starting with, from a healthcare perspective or healthcare provider perspective, a lack of education of healthcare providers about the benefits of breastfeeding, the real importance of it. Not only benefits compared to breast milk or compared to infant formula, but the normalization, the optimization of health as a result of breastfeeding.
Let's move to our seventh question. According to the analysis of the NHANES study data, children have inadequate intakes of food, which is rich in calcium, in potassium, in vitamin D, in dietary fiber, including dairy foods, vegetables, fruits, seafood, and whole grains. What tips can you use to moderate or overcome that real challenge? I mean, I see that in my kids also, so it's a bit of a challenge. And sometimes I tell them, like, this is what we have, guys.
Yeah. Well, I think there's a couple of things that parents really need to do. They need to understand that the foods they bring into the house are the foods that their child will eat. And so if they bring foods in that are not in those, healthy food categories, then they should be available to the child, or the child will want those foods. Yeah. So really it comes down to parenting, the same way that we make other parenting decisions, and making the healthy choices, the available choices. It also means role modeling. We can't expect children to eat foods that their parents won't eat. So, many times I talk to parents, and the parents say, well, my child won't eat a vegetable. And I say, well, what vegetables do you eat? And they tell me, well, I don't like vegetables. And I have to say, how can you expect your child to eat vegetables if they don't see you eat vegetables? I mean, the parents are their the primary role models for the first, 10 years of life. And so if a child doesn't see the parent eating those foods, they won't eat them themselves. They also, parents have to be empowered to make the right choices when they go out in the food environment. We're surrounded by all of these other alternatives all the time. And so parents need to make the choice not to necessarily go to the fast food outlet when they go out, but to plan ahead or to make better choices. You can go into the grocery store and get fruit instead of going into McDonald's to get French fries. But it's a choice that they have to make, because it's an ongoing battle. But if we model for children that they have that choice, then, as they get to the period where they go off to school, or they have more choices on their own, we have a better chance of them making the better choice than, the easy fast food or processed food choice.
Let's move to our eighth question. Improving the diet quality and health of children is a multifaceted approach. One main challenge is the caregiver or the parent. I'm going with like 8 questions now. What are the things you look for as sources of issues for the child originating from the parent, and how to address it? That's like very blunt now.
Well, I think that we start with the parents' expectations. What are the parents' expectations? Are the parents' expectations of the child appropriate? Are they realistic? Sometimes we have parents that really expect the child to be able to make those food choices, as I said, without them modeling those choices, or to be able to make those food choices from within the range of poor options that might be available to them. So we have to start with the parents' expectations and make sure that they're appropriate. We also have to look at the match between the style and the personality of the child and the style and the personality of the parent, because sometimes there's a real mismatch there.
Yeah.
And so, it's just sort of like they're continually butting heads. They're coming against each other because they have just a really different styles. And parents sometimes just don't understand that style of their child. We also need to, look for how well they're paying attention to the child's cues. Is the parent able to pick up on what the child's cues are for hunger and fullness? Because if they're not, then there's a tendency for the parent to try to override what the child's cues are. And that leads to a lot of problems that we see in feeding and eating problems for kids.
This is very interesting. Dr. Leonberg, I'd like to thank you very much for being with us today. And we'd love to have you again with us in the Middle East. Thank you for your valuable input on those 8 questions. I'm sure if we go through them point by point, we can extrapolate from that a lot of very valuable clinical skills that we can use on our daily practices. Dr. Leonberg, thank you very much, and hope to see you soon again in the Middle East. Thank you.
Thank you.